A very good morning, everyone. I'm Dr. Shane Jayachandra, first year surgical resident at SLIMS. Today, I'm going to take a class on thromboangiitis obliterans, or TAO. Before going to the main topic, let's have a slight discussion on the arteries of the upper limb. The right subclavian artery begins from the brachiocephalic trunk, whereas left subclavian artery arises directly from the arch of aorta. From underneath the sternoclavicular joint, artery arches over the pleura and apex of the lung about 2.5 centimeters above the clavicle, and then reaches the lateral border of the first rib to continue as axillary artery. Subclavian artery is divided into three parts by scalenus anterior muscle. Axillary artery is divided into three parts by pectoralis minor muscle. At the lower border of teres major muscle, it enters the arm and continues as brachial artery. About 2.5 centimeters below the crease of the elbow joint, it bifurcates into radial and ulnar arteries, which run in the forearm. Ulnar artery forms the superficial palmar arch, which is completed by superficial palmar arch of branch of radial artery. Radial artery, after passing through the anatomical snuff box, enters the dorsum of hand and first intermetacarpal space to form deep palmar arch. It is completed by deep palmar branch of ulnar artery and is 1 centimeter proximal to the superficial palmar arch. More arteries of the lower limb. Abdominal aorta bifurcates at the level of fourth lumbar vertebra. It corresponds to the level of umbilicus in the anterior abdominal wall into the two common iliac arteries. Common iliac artery is about 5 centimeters in length, passes downwards and laterally, and at the end of lumbosacral vertebral disc, anterior to sac joint, that means sacroiliac joint, it divides into external and internal iliac arteries. Internal iliac artery supplies pelvic organs. External iliac artery continues as common femoral artery at the level of inguinal ligament. About 5 centimeters below the inguinal ligament, common femoral artery divides into superficial femoral and deep femoral arteries. Deep femoral provides collateral circulation around the knee joint and also communicates above the gluteal vessels to maintain collateral circulation around the gluteal region. Superficial femoral artery at the hiatus in the adductor magnus continues as popliteal artery up to the inferior angle of popliteal fossa, where it divides into anterior and posterior tibial arteries. Anterior tibial artery supplies anterior compartment of leg and ankle, continues as dorsalis pedis artery, which forms dorsal arterial arch of foot. Posterior tibial artery supplies posterior compartment of leg and ends as medial and lateral plantar arteries, which forms plantar arterial arch of the foot. Posterior tibial artery gives peroneal artery, which runs close to the fibula, supplying calf muscles. Now to the main topic, thromboangiitis obliterans, or TAO. It is also known as Buerger's disease. It is a disease very commonly seen in young and middle-aged males, but seen only in smokers and tobacco users. Not usually seen in females, but due to some reasons, it can occur in females also, probably genetic. Almost always, it starts in the lower limb. It may start on one side and later on the other side. Upper limb involvement occurs only after the lower limb is diseased. Only upper limb involvement can occur, but it is also rare. It is a excuse me. It is non-atherosclerotic inflammatory disorder involving medium-sized and distal vessels with cell-mediated sensitivity to type 1 and type 3 collagen. It is very common in Jewish. Hormonal influence, familial nature, hypersensitivity to cigarettes, altered autonomic functions are probable different causes. It is even rare in female smokers. Lower socioeconomic group, recurrent minor feet injuries, poor hygiene are other factors. It is a segmental, progressive, occlusive, inflammatory disease of small and medium-sized vessels, with superficial thrombophlebitis often may present as Raynaud's phenomenon, with microabscess along with neutrophil and giant cell infiltration with gut lesions. Pathogenesis. Smoke contains carbon monoxide and nicotinic acid, along with carboxyhemoglobin. It causes initially vasospasm and hyperplasia of intima. Thrombosis and obliteration of vessels occur. Commonly, the medium-sized vessels are involved. Panarteritis is common, usually involvement is segmental. Eventually, artery, vein, nerve are together involved. Nerve involvement causes rest pain. Patient presents with features of ischemia in the limb. Once blockage occurs, plenty of collaterals open up, depending on the size of blockage. It can be either around the knee joint or around buttock. Once collaterals open up, through these collaterals, blood supply is maintained to the ischemic area. It is called compensatory peripheral vascular disease. Now, if the patient continues to smoke, disease progresses into the collaterals, blocking them eventually, leading to severe ischemia, and is called as decompensatory peripheral vascular disease. It is presently called as critical limb ischemia. It causes rest pain, ulceration, and gangrene. Smoking index is the number of cigarettes smoked per day multiplied by number of years of smoking. If smoking index is more than 300, it's a risk factor. Pack years index. It is number of years of smoking into number of packets of cigarettes per day. If pack year index is more than 40, it's also a risk factor. Now, coming to Shionoya's criteria for Buerger's disease, tobacco use only in males. Disease starts before 45 years. Distal extremity involved first without embolic or atherosclerotic features. Absence of diabetes mellitus or hyperlipidemia, with or without thrombophlebitis. Classification of TAO. There are 5 types. The first one is upper limb TAO, which is rare. Type 2, which involves the limbs, lower limb, legs and feet, crural or infrapopliteal. Type 3 is femoral-popliteal. Type 4 is also iliofemoral. Type 5 is generalized. Clinical features. It is common in male smokers between 20 to 40 years of age. It's a smoker's disease. Intermittent claudication in foot and cough, progressing to rest pain, ulceration, and gangrene. Recurrent migratory superficial thrombophlebitis may occur. Absence of feeble pulses distal to proximal dorsalis pedis for posterior tibial, popliteal, femoral arteries may be there. It also may present as Raynaud's phenomenon. Here you can see this dry gangrene of the leg. The patient needs to have the above amputation. Here you can see gangrene of all the toes of the foot of the TAO patient. In this picture, you can see bilateral TAO causing gangrene of both feet. The patient has to have amputation on both sides. Here also you can see gangrene of foot. And this is ischemic ulcer of foot, in a TAO patient. Now coming to investigations. You take hemoglobin levels, blood sugar, arterial Doppler and duplex scan, transbrachial angiogram. If femorals are not present, then transbrachial angiogram, which is done through left side of brachial artery, left subclavian artery, and so to descending aorta. Should ultrasound abdomen to see abdominal blood or aneurysm is also done. Transfemoral retrograde angiogram through Seldinger technique. It shows blockage, size, extent, and severity. The corkscrew appearance of the vessel due to dilatation of vasa vasorosum, vasa vasora, inverted tree or spider leg collaterals, severe vasospasm causing corrugated or rippled artery. Distal runoff is amount of dye filling in the main vessel distal to the obstruction through collaterals. If distal runoff is good, then ischemia is compensated. If distal runoff is poor, then ischemia is decompensated. Then we do take vein, artery, and nerve biopsy. Treatment. The first thing that we have to ask the patient to do is to stop smoking. You can even ask them if you want your limbs or do you want to smoke. The drugs we use are pentoxiflin, which increases the flexibility of RBC and helps them reach the microcirculation in a better way so as to increase oxygenation. We give low dose of aspirin, 75 mg, as a OD dose. It has an antithrombin activity. Then we also administer the patient. We can also give them prostacyclins, ticlopidin, Praxilin, carnitine, clopidogrel, atorvastatin, parostatin, cilostazol, which is a phosphodiesterase inhibitor, which improves circulation, and it is considered to be an ideal drug. Now, then we give naftidopril. It's a useful in intermittent claudication as it alters the tissue metabolism. Analgesics, sedatives, anti-lipid drugs like atorvastatin may be needed. Graded injection of xanthine nocosnate, 3,000 milligrams from day 1 to 9,000 milligrams on day 5 is often practiced to promote ulcer healing. Helps to increase claudication distance as temporary basis. Low molecular dextran may also be used. There is gene therapy. Intramuscular injection of vascular endothelial growth factor, VEGF, which is an endothelial cell antigen that promotes angiogenesis, may help. Chemical sympathectomy. The sympathetic chain is blocked to achieve vasodilation by injecting local anesthetic agent, which is xylocaine 1%, paraversibly besides the bodies of L2 to L3 and L4 vertebra in front of lumbar fascia to achieve temporary benefit. Local time efficacy can be achieved by using 5 ml phenol in water. It is done under C-arm guidance. After having the injection, feet will become warm immediately. Possible risk of injecting phenol into IVC or aorta, spinal cord ischemia may occur. Now, surgical management. There are a couple of surgical management which we can do. Omentoplasty to revascularize the affected limb. Prophyloplasty is done for blockage in profundifemoral artery so as to open more collaterals across the knee joint. It often makes better perfusion treatment. Lumbar sympathectomy to increase cutaneous perforation so as to promote ulcer healing. It may divert blood from muscles towards skin, causing more ischemic knee joint and the flap below the knee amputation. This is a patient having done sympathectomy. Patient has undergone right-sided above knee amputation and left-sided lumbar sympathectomy. Ischemic ulcer on the left foot is also seen here. Amputations. Amputations are done at different levels depending on site, severity, and the extent of vessel occlusion. Usually either below knee or above knee amputations are done. Elizaro's method of bone lengthening helps in improving the wrist pain and claudication by creating neo-osteogenesis and improving the overall blood supply of the limb. Care of limbs. Burgers position and exercise is usually done on a regular graded exercises up to the point of claudication improves collateral circulation. In Burgess position, head end of bed is raised, foot end of bed is lowered to improve circulation. In Burgess exercise of leg is elevated and lowered alternatively, each for 2 minutes or several times at a time. Care of feet. Exposure of feet to more cold and warm temperature should be avoided. Trauma, even minor like nail paring or pressure at pressure points in feet should be avoided. Dryness of feet and legs should be avoided by applying oil to feet and legs. Footwear should be selected carefully. It is better to wear socks with footwear. Heel raised by raising the heels of shoes by 2 centimeters decreases the calf muscle work to improve coordination. Guys, since it's a very important topic, let's look again at clinical features, investigations, and more of treatment, shall we? If you don't mind. The clinical features are it's more common in males around 20 to 40 years of age. It's a smoker's disease. Intermittent claudication in foot and cough, progressing to wrist pain, ulceration, and gangrene. Recurrent migratory superficial thrombophlebitis and absence of feeble pulses distal to proximal dorsalis pedis, posterior tibial, popliteal, femoral arteries will be there. It may present as Raynaud's phenomenon. Now, these are the pictures showing the dry gangrene of foot, gangrene of all toes here, bilateral gangrene of lower limb, gangrene of foot, and ischemic ulcer. Investigations. Now, we usually take all the blood work, which equals hemoglobin levels, blood sugars, arterial Doppler and Doppler scan, transbrachial angiogram. If femorals are not felt, then transbrachial angiogram should be done. It's done to the left side brachial artery, to the left subclavian artery, and so to the descending aorta. Ultrasound abdomen must be done to see any to block or aneurysm. Transfemoral retrograde angiogram through Seldinger technique shows the size, extent, and severity of blockage. Cross-screw appearance of the vessel is due to dilatation of vasa vasorum. Inverted tree or spider leg collaterals may be seen. Severe vasospasm causing corrugated or ripple artery may be seen. Distal runoff is the amount of dye filling in the main vessel distal to the obstruction through collaterals. If distal runoff is good, then ischemia is compensated. If distal runoff is poor, then ischemia is decompensated. And we take vein, artery, and nerve biopsy. Treatment. The first thing we do is ask patients to stop smoking. We all ask them if you want to smoke or do you want your limbs. Pentosyphilin is a drug which increases the flexibility of RBCs and helps them reach the microcirculation in a better way so as to increase oxygenation. Low dose of aspirin, 75 mg once a day, for its antithrombin activity. Prostacyclins, teclopidine, praxilin, carnitine are also used. Clopidogrel 75 mg, atorvastatin 10 mg, parvostatin 40 mg, Slastazole 100 mg as a BD is given as it's a phosphodiesterase inhibitor. It improves circulation. It is considered to be an ideal drug. Naftidopril is useful in intermittent claudication. It alters the tissue metabolism. Analgesics, often sedatives, antilipids, like atorvastatin, will be needed. Graded injection of xanthine nocotinate 3000 mg from day 1 to 9000 mg on day 5 is often practiced to promote ulcer healing, helps to increase claudication distance as a temporary basis. Low molecular dextran may also be used. Gene therapy. Intramuscular injection of vascular endothelial growth factor, VEGF, which is a endothelial growth antigen, can promote angiogenesis. Chemical sympathectomy. Sympathectomy, sympathetic chain is blocked to achieve vasodilation by injecting local anesthetic agent, which is 1% of xylocaine, paravertebrally besides the bodies of L2, L3, and L4 vertebrae into the lumbar fascia to achieve temporary benefit. Long-term efficacy can be achieved by using 5 ml, 5 milliliters of phenol in water. It is done under the guidance of CM. Feet will become warm immediately after injection. Possible risk of infection. Injecting phenol into IVC or aorta. Spinal cord ischemia. Surgical management. Omentoplasty to revascularize the affected limb. Profundoplasty is done for blockage in profunda femoris artery so as to open more collaterals across the knee joint. It often makes a better perfusion treatment. Lumbar sympathectomy is done to increase cutaneous perfusion so as to promote ulcer healing, but it may divert blood from muscles towards skin, causing muscle more ischemic in the knee joint and flap of below the knee amputation. This is an image where the patient has undergone the right-sided above knee amputation. The left foot has an ischemic ulcer, and there is a sympathectomy scar on the side. Amputations done at different levels, depending on site, severity, and extent of vessel occlusion. Usually, either below knee or above knee amputations are done. Lazaro's method of bone lengthening helps in improving the wrist pain and claudication by creating neo-osteogenesis and improving the overall blood supply to the limb. Care of the limb. Rigorous position and exercise. So regular graded exercises up to the point of claudication, which improves the collateral circulation. Burger's position. Head end of the bed is raised, foot end of bed is lowered to improve circulation. Burgess exercise. Leg is elevated and lowered alternatively, each for 2 minutes for several times at a time. Care of feet. Exposure to feet, exposure of feet to more cold or warm temperatures should be avoided. Trauma, even minor, like nail paring or pressure at pressure points in feet should be avoided. Dryness of feet and legs should be avoided by applying oil to feet and legs. Footwear should be selected carefully. It's better to wear socks with footwear. Heel raise by raising the heels of shoes by 2 centimeter, decreases the calf muscle work to improve claudication. Thank you.